So I want to introduce our third speaker of the day. We have Daley. So Daley is a research and outreach coordinator for the University of California, San Francisco Movement Disorders Center, a Parkinson's Foundation Center of Excellence, a position he has held for the past 8 years. In clinic, he educates Parkinson's disease patients and caregivers on the various aspects of Parkinson's and provides connection to community resources. He also heads up several clinical research studies aimed at slowing Parkinson's progression and exploring new study areas such as gene therapy. In addition, he presents outreach community program talks at support groups, Parkinson's events, and community centers. He holds a master's degree in psychology and has worked for the University of California for the past 17 years. Today, Mr. Daley will be presenting to us on the topic of maintaining intimacy as a care partner. So welcome, Daley.
Thank you, everyone. Hopefully you can hear me. All right. A big hello from California. Thank you so much for letting me be a part of this program today. I have a lot to get to, so I'm going to go ahead and jump right in. Okay. All right, as Bree said today, that we're going to be talking about intimacy and how it relates to being a care partner and Parkinson's disease. I'd like to take a moment just to thank the Parkinson's Foundation. Part of this program was created using some slides that the Parkinson's Foundation funded for a caregiver series that I made about 5 years ago. And I just want to acknowledge and thank them for that. So we'll jump right in. I think this is a really great quote to start out this talk. This is from Michael J. Fox, who obviously might be one of the most famous people that we know of that has Parkinson's currently. So what I say about Tracy, which is his wife, is this: Tracy's big challenge is not having a Parkinson's patient for a husband, it's having me for a husband, and I happen to be a Parkinson's patient. I think this is a really great way of introducing the idea that while Parkinson's may be the main program of what we're talking about today, it's important to remember that this is also a spouse, this is a parent, this is somebody who we have a close relationship with, and we want to think about all the things that make up that person and not just focusing always on the Parkinson's disease. So what are some of the relationship issues that people with Parkinson's and their partners report? This was from a study done in 2016, and the general idea was that there was really only a small amount of people that reported any sort of decrease in closeness between their partner and themselves with a diagnosis of Parkinson's, but more that identities may have to shift as far as who carries the majority of some of the roles in the house. Financial stress, I think, which isn't necessarily true just for Parkinson's, but all of us, I think, can be a big source of stress. And the fact that maybe social activities, leisure activities may have to change or be altered in a way that is more inclusive to the person who may be hindered by some of the activities due to Parkinson's. And again, just the uncertainty of the relationship. I think a lot of people with Parkinson's obviously start to have a fear that they don't want to be dependent on their spouse or care partner in a way that makes them resent them because of the disease that they have. So some of the things that we're going to be covering, so sort of, as I mentioned before, the new dynamics maybe of a relationship, some of the communication challenges, which we know can be a big problem, emotional changes that may occur between a person with Parkinson's and their care partner, as well as building and or rebuilding intimacy between two. So first, just touching on this. So the dynamic, as I said, that may change really challenges the sort of pre-Parkinson's identity. And the problem that we see most often is that care partners may start to feel that they are more in a parental role rather than a spousal role. And again, it may challenge some of these perceptions of marriage as far as what we have traditionally been taught or what we traditionally have brought up to believe as far as who has the responsibility for what in a household. And again, this invoking these feelings of dependency can be, I think, quite destructive for a person with Parkinson's who suddenly feels as though they're not able to contribute as much as maybe they used to. Again, maybe breadwinner identities, so the employment changes that may shift, again, these relationships or the identity of a person that they have long held. There may be an increase in the protective instincts related to maybe an increased closeness, but a shifting focus. And again, just acknowledging that we have these preconceived notions, unfortunately, about marriage, about role identity, and those may be challenged due to some of the some of the symptoms of Parkinson's as they progress. So one of the things I'm going to be using through this talk is excerpts from a series of journals. I was gifted 17 journals about 5 years ago from a family who their parents had the father had Parkinson's and he was diagnosed, and he had asked his wife to basically chronicle the day-to-day changes in his symptoms as a way of tracking maybe progression. He was also a scientist and he just wanted to catalog this. What this journal quickly became, though, was an outlet for Jane Doe, as we will refer to her, for her to just express all of the frustrations, all of the emotional lability that she would have through the day and through the years dealing with her husband. So he was on basically 6 tabs of carbidopa-levodopa per day. His primary symptoms were tremors, the stiffness, the slowness. He had chronic constipation and urinary frequency and nocturia, which means having to get up several times at night to go to the bathroom. He also had balance issues. He also had quite variable mood and cognitive dysfunction that really did seem to sort of leapfrog through the weeks, through the months. At times he would be very up, and at other times he would be very low. So this is just a few excerpts from her as the primary caregiver. So then he wanted to talk and he got me into tears. So he's scared of the future. So he's afraid of falling. So he's frustrated. Aren't these common to all people? And I think that really just speaks to the fact that you want somebody that you are working with, through a disease like this to kind of pull their own weight and also be an active part of this journey. And I think probably the best quote here is the bottom one, where she says, "What I don't understand is what he expects from me. I have to be 2 people, the subservient, obedient wife and the competent, organized adult at the same time. And sometimes he doesn't particularly like either one of me." And I think that is a really great quote, just because it shows the sort of duality of what care partners often are faced with, where they may have to take on a lot of additional things, but also have to sort of maintain those traditional or main roles that they have inhabited for several years during this partnership, but now taking on all of these additional things. What are some of the communication challenges? So we know that people with Parkinson's, their voice can be definitely impacted. Communications in general, so we know that the softness, the voice becomes quieter. People with Parkinson's may mumble more. We definitely know that there's a loss of facial expression due to the rigidity of the facial muscles, which makes it look as though the person has a less expressive face. There can be trouble swallowing. And there may be difficulty finding words, that sort of tip of the tongue phenomenon. The problems that these can result in are things like misunderstandings between 2 people, requiring repetition, the patience that may come about because of that, the frustration involved with that, and also the person with Parkinson's own perception of maybe how that affects their own attractiveness as far as their ability to communicate and or their faces. What are some of the things that can be done about that? So voice hygiene, which is basically doing exercises, consulting with a formal speech pathologist. There is a program called the Lee Silverman vocal technique, which is specific for people with Parkinson's. It is an intensive series. I believe it is 4 weeks every day. And it teaches a number of exercises. It teaches people to speak from their diaphragms. It speaks people to really enunciate their words. The great thing is that this is sort of like physical therapy for the voice. And we can see the results of it for many years afterwards. And if persons continue to do those exercises after the initial program has finished, we can really see a different change and a much improved as far as voice, as far as pronunciation, as far as volume. For the care partners, making sure to face the person with Parkinson's when you're talking, try to decrease any background noise. And try not to rely on facial expressions to determine the sort of understanding. And why we say that is because, as I said, that the people with Parkinson's can have a very masked face. So their expressions can become very muted. And the issue with that is that starts to look as though the person's not paying attention or they are not understanding what you are saying, when in fact they are understanding and very clearly understanding what you're saying. But we give all of these micro expressions in our face to show interaction, to show that we are following a person while they're talking. And a person with Parkinson's, those muscles basically are more rigid and not allowed to give all of those little micro expressions, which then makes a person feel as though they aren't being heard when in fact they are. And again, being patient, making sure that to allow a person with Parkinson's to find the space and time to find words, not filling in words, not finishing sentences for people, but giving them sort of the floor to express themselves. What are some of the nonverbal communications? I think, as I have covered already, there may be limited gestures due to rigidity, that masking may limit these sorts of facial expressions and these micro expressions, nonverbal cues. The fact that some people with Parkinson's have a very bent posture means that they will have sort of limited eye contact they can provide during a conversation. And that the fact that this actually limits the positive nonverbal communications so that everything is sort of viewed as negative or neutral. And the issue, I think, more than anything, is that people with Parkinson's may not understand or be aware that these are the changes that are happening. And so trying to alert them to the fact that, we need more face-to-face contact, we need eye contact, we need speaking clearly, all of these things, and doing so in a way that doesn't sound as though either the person is doing it on purpose or, that somehow, that they are made to feel somehow less by presenting the fact that you need a little bit more interaction. So emotional and psychological challenges. We know that anxiety and depression are rampant in people with Parkinson's. We know that definitely at an increased risk, almost to the point that we consider it a true symptom of Parkinson's. But we know that caregivers are also at an increased risk for poor emotional health. And I think what I like to tell all the caregivers is, if you don't take care of yourself, how can you really expect to take care of someone else long-term? And that one outcome really does dictate the outcome of the other. If a caregiver does well and takes care of themselves, the person with Parkinson's is also going to do better. The problems that depression and anxiety may lead to are things like a withdrawal of intimacy or mutuality. There's going to be increased conflict. And there may be just a lot of fatigue, excessive sleepiness, apathy, which we also know to be symptoms of Parkinson's as well, but can definitely be exacerbated by depression and anxiety. So we're gonna hit back to the journals. So this is from 1990, and this is John Doe's daily routine. And we're all gonna play sort of amateur neurologists here for a moment. And I want you to think about all of these things. And I want you to identify maybe some of the red flags, some of the problems that you see in this daily routine. So John wakes up his wife at 6 a.m. and demands help getting dressed. He may or may not eat breakfast. He falls asleep at the dining table. He wakes up at 7:45 a.m. and she tells him to go lie down. He is obstinate and he sleeps at the table, or he moves to the living room chair downstairs bedroom and he sleeps again until 11. He wakes intermittently between 11 and 1. His wife comes home, they eat lunch, he watches TV, or he works on his stamp collections. He falls asleep again at 3. He wakes again at 6. He has dinner. He falls back asleep until 11:30, then goes to bed with his wife, but is then up and down between 1 and 6 with frequent bathroom visits. He will sit in an office desk in front of the TV, maybe have short stints of sleep, and the whole cycle starts again at 6 a.m. when he wakes his wife up and demands her help in getting dressed. Maybe take 10 seconds and just try to identify one thing in particular that you see wrong with this. And we will move on. So some of the things that I would say are probably the biggest issues is, that he demands help getting dressed. He doesn't even try to do things for himself. What we always counsel patients to and their care partners is that you try to remain as independent as possible for as long as possible. The problem being that if you start to get help in doing something, you're eventually going to lose the ability to do that action. So taking the extra 10 seconds to get the button buttoned or the cuff button done, tie the shoes, put the pants on, those sorts of things are all basically sort of mini versions of physical therapy. And it's important for the person with Parkinson's to continue to try and do those things, because if they are constantly getting help and doing them, there will be a moment when they are just not able to do it anymore. So he doesn't even try. He demands help first thing in the morning. He then sleeps basically through the day. So this is a terrible sleep hygiene routine where he is sleeping during the day. He's not sleeping in bed. He's sleeping all over the house. He's watching TV if he's not sleeping. He is up and down. He's sleeping at the table. And then when he, where is the fact when he goes for a walk? Where is the fact when he interacts with someone other than his wife during a meal? Where is the independence? Where is he trying? Where is he continuing to try and live a life? So you can see that there are a lot of red flags in this sort of daily routine. So I'd like to just touch on a couple of the things. First of all, it's pretty clear that this guy is very depressed. I mean, these are some very constant signs of depression. The fact that he has no interest in interacting with people, the fact that he is fairly irritable, the fact that he sleeps for a majority of the day, the fact that he has little interest in trying. These are all really constant signs of depression. And I hope that everybody sort of understands that some of these signs, it doesn't always have to be depression as we may think of it, but that it's something like being apathetic, being irritable, having a pessimistic attitude towards things, daytime sleepiness, which also unfortunately, can be part of Parkinson's disease. And so we really sort of, have to take one with the other. But how do we address these sorts of things? Depression, as I said, it's probably part of the Parkinson's disease pathology. It may also be as a result of the fact that the person's been diagnosed with Parkinson's and that they are having some trouble adjusting and coping with that. The good news is there's been a lot of advances since the time of John Doe in 1990 that Parkinson's, medications and in particular antidepressants can be used. And that depression and caregiving as well, basically what works for the patient will also work for the caregiver. And depression and caregiver is very, very common, mostly as a result of the fact that there is this shift, there is this increased number of things and stress, the focus on the patient rather than their own health, other factors, obviously. And I think that one of the most important things for caregivers is that support groups can be a really great part of treating that depression. And obviously programs like this and the other ones that I saw advertised as being run through the Parkinson's Association of Alberta look really great for acknowledging and trying to help with a lot of these issues where the very nature of hearing someone else expressing a similar problem related to their spouse or their partner can be really, really important. I think really validating to helping deal with your own feelings. I would like to say, and hopefully this has been hammered on a lot, but that physical and social activity really does benefit both patient as well as care partner. It's one of the best treatments for depression. It can be as easy as just walking for 30 minutes a day. It is something that patients and care partners can do together. We know for a fact that sunlight is great for the mood. It's great for the production of vitamin D. And exposure to sunlight actually does help with maintaining these circadian rhythms, which actually lead to more restful sleep, but also lead to sleep when people are supposed to be sleeping, which is at night. So daytime sleepiness obviously can be an issue, but it's really important to make sure that you are maintaining a normal sleep cycle. We also know that socially active adults, so not just physically active, but socially active, have lower mortality rates. They have better physical functioning and higher cognitive functioning. Volunteering and sustained social interactions are also beneficial to mental health. there is a real dynamic relationship actually between social involvement that is initiated that can actually be protective of mental health. And that actually goes above and beyond the sort of individual differences that may exist between social circumstances or specific health statuses. I think the main takeaway for something like this is the fact that it's never too late really to get the benefits of interacting socially. So it doesn't have to be, you know, something that you do every single day, but it needs to be a part, much like walking every day, there needs to be some social interaction. I think one of the things that we really learned during the lockdowns of COVID was that everybody really did worse across the board when they were limited in their ability to interact with other people. And I think that that's something that really is hammered home. And hopefully, as we are coming out of this, people are able to start getting together and interacting in social ways, because I think it's a really necessary aspect. So just a few comments, I think, from the journals as far as maybe some of the things that a care partner might feel as far as frustration, as far as anger and exhaustion. So one of the things that I think I hear a lot from care partners is in this first quote, where she says that John resents my health and his dependence on me. So I think often we feel that people with Parkinson's obviously don't want to have Parkinson's. They also don't want to be a burden to someone else. And I think that that sort of thing on a day-to-day basis can build some resentment. That she also acknowledges here that yesterday he was feeling very sorry for himself. He feels that he is invisible to other people who only see his illness. And I think that is a really important point, that people with Parkinson's obviously have Parkinson's, and it sometimes is a very visual thing, the tremor being the most obvious part. But I think that it's also important to remember that this is a whole person you're dealing with. This is not just Parkinson's disease that's attached to a person, and all you talk about, all you interact, all you do is talk about the Parkinson's disease. There needs to be acknowledgement that there's a full person behind that. So I think she does a really great job of saying, you know, that he must feel so helpless and furious, and that she needs to be aware of that. And I think that's really important to make sure to remember that there is a whole person behind this disease as well, and that Parkinson's should be a part of that person, but it shouldn't be everything about everything. And I think just this bottom quote as well is really important, because it acknowledges the humanity that we all feel, which is, you know, that she says, I came downstairs to lock up, to do the pills, have a little cry, and then upstairs to bed at 11:15. And I think that allowing herself and also expressing that, that sort of emotional fragility, that it's important too, that we need to grieve. We need to be sad about this, but it's also part of the whole life, that it isn't something that you allow to just take away all the enjoyment, all the possibilities for the future, but that allowing yourself to cry, allowing yourself to be emotional about this, and allowing yourself to grieve about this, in a way that's healthy without being overburdening, I think is really important. What are some of the strategies that you as caregivers can do to deal with this stress? I think most importantly is being able to accept help, being able to have a list of things that if a person said, you know, is there anything that I can do for you? Be able to say, yes, actually, there's something that you could do. Could you bring by, you know, a couple of apples, because my spouse really loves apples and I sometimes forget to get them. Or being able to focus on what you are able to do, you know, being able to do the best that you can, but also acknowledge that you need to be realistic. Being able to break things down into smaller steps, being able to prioritize, making sure lists become very, very easy as ways of both establishing that you have a daily routine and also that the person with Parkinson's has a daily routine, and being okay with the ability to say no, about being able to say that some things are just too much. I think, as I will reiterate, that being connected with things like support groups, finding out what sort of resources are in your community. The Parkinson's Foundation has a lot of great resources related to caregivers, but there also are local places that you can acknowledge. Support group, I think, is really, really important for care partners, because I think you get a lot of validation, but you also get a lot of good strategies that are more real world, but also sitting in a group of people who are on that sort of same journey as you are, and being able to say, you know, my husband has this issue, and someone else say, you know what, my wife had that exact same issue 5 years ago, and we did this, this, and this, and it seemed to work, you know, about 80% of the time. And, you know, for 80% of the time, something to be working, that feels like a real win. I think just underlining that social support, you know, with friends and family as well, being able to set aside time that for connecting with them, even if it is a walk, which again, you know, is sort of that social and physical activity that we're really looking for. Being able to set personal health goals, make sure that you're taking care of yourself, making sure that you're drinking plenty of water, making sure that your sleep routine is really well established. I think a lot of caregivers have issues with sleep. This can come about because of, as I said, that nocturia is one of those issues that people with Parkinson's can face, where they're getting up a lot during the night to go to the bathroom. And also just making sure, you know, as far as taking care of your own health, that you are doing your own doctor's visits. I think that too often care partners can get locked into the doctor's visits for the person with Parkinson's, and they neglect to go on their own to see their own physicians and follow up on their own health issues. So we will shift into building and rebuilding intimacy now. What are some of the things that can affect intimacy? So obviously new stressors like a diagnosis of Parkinson's, like the changing in symptoms of Parkinson's. These dynamics can obviously impact a lot of the identity, which I think we've touched on already. And the dependency can actually affect the self-image. Also said that, you know, a person with Parkinson's may feel less attractive based on the fact that their care partner or their spouse is starting to take care of them more and more with day-to-day activities. What are the 4 types of intimacy when we talk about that? So we talk about couple time. So this is just quality time, you know, doing things that both people enjoy. There's actually personal time, so time to oneself. So the separations actually are a way of improving intimacy because you are satisfying some of the needs and the things that are most important and interesting to you. And it also, I think, establishes that, you know, there's a lot of truth to the saying that, you know, absence makes the heart grow fonder. And even if that absence is only for a few hours, it does strengthen then that when you come together. Then there is intimate time, so emotionally and physically being able to share thoughts and feelings. You know, this is sort of in the non-erotic zone. And then what we, you know, obviously have sexual intimacy, so activity with the goal of sexual arousal and satisfaction. So what are some of the ways that you can do? One of the most important things is just spending time together. Again, COVID, I think, has taught us that we're able to spend time together, maybe even more than we ever thought that we would. But, you know, making sure that we are doing this outside of just sort of the day-to-day tasks. And it doesn't need to be extravagant. You know, it can be things as simple as just making sure that you're having, you know, meals together, you're going for walks together, which I guess I have to continue to hammer home that, you know, physical exercise is so important. Reading to each other. I think that can actually be a really intimate way of spending time together, and being able to spend day trips, weekend getaways. You know, if it's a day trip, making sure that you're planning the trip during a time when the person with Parkinson's obviously is at their best to travel, and being able to be mindful of that if the person has medication fluctuations, that sort of thing. Some other ways is just being able to interact, to laugh, to give each other time, you know, giving each other room to also not talk about issues if things get too heavy, but being able to kind of have a way of saying, you know what, I don't think that I can necessarily talk about this anymore. You know, is there a way that we can kind of just step away from it and come back to it? I think it's a really nice quote to say, to turn towards each other rather than away. And making sure that, you know, you really are relying on each other for support and not to shut each other out, being able to show empathy and compassion. I think that it's really important, and I think we really do like to hear when someone else appreciates us and appreciates the thing we are doing. I know that, you know, sometimes care partners can become a little bitter because they feel like they've taken on so much extra, and, you know, that it really can all be aided by just a simple act of, I really appreciate the extra things that you've done and the new things that you've had to take on. You're such a strong person. And I think that being able to have things like that expressed are really important. And being able to express your needs. We never want to be guessing what the other person is thinking. We want to give them space to be able to sometimes understand that they may not know what they are quite thinking, or being able to formulate it into a sort of cogent statement quite a way. But that you want to be able to be available, and also that you don't want to always be guessing what the other person is thinking. And then also just sharing, what are the things that you like? What are the things that may bring you together? So I think the power of touch is a really important part of rebuilding intimacy. Again, it sort of builds this sense of safety, of comfort. And I think that just, the touch of one human to another is a really important thing. And all of these ways, being able to hug, being able to share a blanket on the couch, foot massages, manicures, pedicures, washing each other's hair. These are all ways that we sort of have a really direct link to intimacy, and a way of showing that we really love and care for somebody. And they're very simple ways. They're very much like being able to just say, I appreciate you. Being able to give somebody a hug, I think can do a lot more. Staying positive, I think, is another really important way of sort of maintaining intimacy. Making sure, as I said, as you are saying, that you appreciate each other, but also keeping in mind some of those positive attributes. And I think too often people can get really caught up in the frustrations of the day-to-day grind, but making sure to always kind of remind each other, of the love that you share. And being able to express interests in each other's hobbies, being able to both show and listen when someone wants to demonstrate these things. I think that, again, reading, finding passages, continuing to learn about your spouse or your partner, I think is a really important aspect, and a great way of keeping that intimacy alive. And making sure that, again, that it doesn't always have to be about Parkinson's, that that there is a whole person there that has a heart, that has a brain, that has feelings and emotions, and being able to acknowledge all of that. What are some of the ways that I have spoken with care partners about ways of maybe rebuilding or keeping intimacy alive? One of the greatest things is just reminiscing about the life that you've had up until that point, and acknowledging that there are further adventures that are still to come. Talking about, maybe your first date. Maybe you both have a very different idea of what that first date was like, which I think can be a really interesting conversation. Playing games like 20 questions, where you're actually still learning things about someone that maybe you've been married to already for 20, 25 years. We are constantly needing to learn more things. Being able to play your partner your favorite song, or taking turns, playing songs from YouTube, where you try and guess who the band is, or talking about a particular song. I think that music has a really great way of instilling a lot of memory in us, and certain songs take us back to a very specific and sometimes very poignant place. And being able to share that with your partner, I think, is actually a really bonding activity. Maybe it's something as simple as identifying a book and having sort of a book club for two, and reading a book, discussing it together, being able to talk about what you take away from each one, as it can actually be a really interesting way of learning more. Things like weekly game nights, date nights are really important. Having check-ins, the old saying of never going to bed angry, I think, is really important. The separation from electronics and being able to focus on your partner, which unfortunately is something that we've had to say more and more. It's really hard to have a heart-to-heart conversation with somebody who's staring at their phone or their iPad all the time. And it may be easier than talking about emotions. It may be easier than interacting at an emotional level, but there really needs to be a time every single day, at least, where the electronics are put aside, where the TV is turned off, and there is some sort of interaction happening between two people. But I think it's so easy to just fall into our phones, but we really do need to look up and make sure that we're continuing to live a life with our partners. starting new projects together. So things like baking, like puzzles, restoring furniture, writing each other love letters, I think is a great idea as a way of sort of keeping or rebuilding some of that intimacy. Being able to put those letters maybe in places where the people don't necessarily always look for letters, and being able to find them. Mailing them actually is also kind of fun, because then it comes through the mail, and there's just sort of that sort of extra added. We all enjoy getting, I think, mail. What are some other ways? I think that not taking each other too seriously, being able to be playful can be really easy. It makes communication a lot easier. Being able to use humor, I think, is an easy way of lightening the mood. Trying to be honest, obviously, the ability to have trust really, I think, relaxes both people, and letting people know that how you're feeling, being able to express yourself, being able to try new ideas, being able to be open to things, and that that one person may have a real interest in something that the other person never knew about, and being able to acknowledge that. And if it's not something that can be done, maybe then being able to support that person if they want to continue to do it. And I think also being able to modernize, being able to keep up with things, and stay in the now rather than always worrying about the future, or always sort of dwelling on the past. Some of the things as far as Parkinson's and affecting relationships, there was a study done here basically where patients were evaluating the effects of Parkinson's on sexuality. And after diagnosis, that a lot of patients did report a decrease in the frequency of sexual intercourse, and decrease in arousal, decrease in satisfaction. Men seem to show deterioration in more domains, including not being able to achieve orgasm, having a fearfulness of the expectations of the partner, and sort of a general dissatisfaction with the relationship sexually. What are some of the ways that the motor symptoms are going to affect sexual function? So the slowness of movement obviously can change the sort of physical ability to perform. The stiffness as well. The tremor may be sort of hard to include when trying to physically touch somebody. Obviously, the limited dexterity may also be an issue, and balance issues, instability, making sure that people are safe. And again, I think what we have talked about before with sort of these changes in the perceived desirability or attractiveness, that a patient with Parkinson's may just feel less desirable and less interested in involving themselves sexually because they don't feel particularly attractive themselves. Some of the non-motor symptoms that may also affect sexual function, constipation obviously can just be very uncomfortable, especially if it's chronic. Bladder dysfunction in the same way. Autonomic dysfunctions that may affect the ability to have erections, or just the sort of sexual response. Hypotension as well, which is basically drops in blood pressure, which also can affect performance and arousal. Sleep disturbances. Obviously, if you're not getting good sleep, you're not going to feel particularly good about most things. You're probably not going to feel particularly attractive or particularly interested in sexual activity as well if you just are not able to get good sleep. And that also could just add to the irritability of both partners. Depression, anxiety, these changes in roles can also, again, just change the self-image and lead to maybe decreased desire. It's well known that people who are depressed are less interested in sexual interaction, and just general fatigue, which can be due to day-to-day grinds, but it also can just be due to the Parkinson's specifically, can also just lead to problems with arousal and just a decreased desire. There are a particular type of medications called agonists, which may result in something called the impulse control disorders. So this actually is the opposite, that people may become hypersexual or have compulsive sexual behaviors. So it's definitely something to speak to the neurologist about if anyone is on a dopamine agonist, and make sure that they are being followed closely, that the questions are being asked, that this can be related to sexual, but it also can be related to other compulsive behaviors like gambling, like shopping. And it's just really important to make sure that there are a lot of check-ins with the neurologist or other medical staff to make sure that none of these issues are happening. Advanced patients with Parkinson's may start to have, some cognitive dysfunction, which may eventually lead to things like dementia, and people with dementia can exhibit some abnormal sexual behavior as well. So what are some of the ways that you can adjust, to some of these changes? Just making sure that you have the ability to have an open conversation with the neurologist or the nurse, whoever it is that you're interacting with on a regular basis, as with regards to the Parkinson's disease. That there are obviously, people whose whole jobs it is, like urologists and gynecologists, that speak about these particular issues, being able to be open and express yourself about these things. I think really important is having the flexibility to have a change from the sort of goal-oriented intercourse where we are talking about, things like achieving orgasm, into more pleasure-oriented, what they call outer course. So things that are everything other than specific sexual intercourse. And the real underscoring point there is pleasure oriented. So making sure that a sexual interaction is pleasurable for both people, regardless of how it ends, regardless of the goal of orgasm being at the end of it, that both people come out of the interaction feeling pleasured, feeling as though they have had some pleasure from the interaction, I think is a really important mindset. And it can be obviously a bit of a shift to be able to start doing that. But I think that the more people explore that and the ability to have these sort of pleasure-oriented interactions, the more pleasurable in general it's going to be. And then obviously that there are counselors that are specific to things like sex counseling, couples therapy, which definitely can also be ways that two people that maybe have some trouble interacting or communicating about these sorts of issues can really have a mediator that's able to discuss them in a way that I think leads them to a much better place. So what are some of the ways? I think the main thing is just taking the pressure off, being able to take your time. So most of the people that we're going to talk to about Parkinson's are going to not really have young children that are still living in the house. So the ability to have more time to devote to these sorts of interactions and intimacy, I think, is something that should be remembered, and being able to make sure that you're acknowledging and using that time. In the same vein, that it doesn't necessarily have to be a one specific time, but it's something that can actually be stretched out over the course of a day almost, that one could start with breakfast and sort of, lead through the day and have sort of a tactile and romantic experience that stretches for several hours, with it not always being the sexual interaction, but more of an elongated romantic interlude. Don't be shy, being able to touch your partner, being able to encourage them how to touch you, being able to share what it is that you like, what are the things that make you feel good, being able to talk about ideas or new experiences that you might like to have. And most importantly, being able to relax. I think that being able to have things like a hot bath, being able to have quiet music, being able to maybe you don't even communicate, but you're quiet for an hour just laying and listening to some sort of soft music. These are all parts of building intimacy that can, I think, eventually lead to much more satisfying experiences. So I'll take a moment here just to say that the next couple of slides, we're obviously going to go a little bit more in depth into more sexual behavior, sexual specific performance issues. If this is something that people are uncomfortable with, then I definitely encourage you just to sort of mute or step away from the screen at this time. And we hopefully will be done with this in about 5 minutes or so, and we can lead to the Q&A. But just wanted to give everybody a chance to step away if this is something that they don't feel comfortable listening. So the main goal in sexual intimacy is, again, enjoyment and pleasure, and being able to focus on the comfort, on the relaxation, and the pleasure rather than the performance. So this is really leading back to this sort of stepping away from orgasm-based performance into more pleasure-based. Being able to try and work on the fact of being free from anxiety, being sensitive about maybe the expectations that we grew up with, thoughts of what a man should do, what a woman should do, what a man does not do, those sorts of things. being able to let go and sort of separate, from maybe these thoughts and just go back to what brings me pleasure in my physical body. What are the things that I enjoy doing, enjoy having done to me? And I think a really important question is, what am I a yes to? I think that that's a really important conversation to have with a partner, to be able to say, this is something that I am interested in, or this is something that I'm not interested in, and it's not ever going to be something I'm interested in, but framing it in the way of saying, this is what I am a yes to. These are the things that I do enjoy, that I would enjoy exploring more, always leading towards that positive. So I think that, again, expanding this idea of what we think of as sex, being open to the thing that it can mean many different things, that closeness and intimacy is also expressed in many ways, that it isn't just about the penetrative act of sexual intercourse, that it can be all of the things leading up to that. It's one way of fulfilling sex, but all of these other ways of touching, of kissing, of intimate sexual contact are just as rewarding. And again, it's really leading towards that pleasure-based model. Acknowledging that there are changes as we age, obviously, that maybe there are new or better, more satisfying ways of sexual contact and intimacy as we get older. That maybe having intercourse less than you used to isn't necessarily a bad thing if you continue to be close, and if you continue to love and treat each other and try to pleasure one another in any way that you can. Being able to be, acknowledge the fact that some sexual positions are not going to be as comfortable as they used to be. It doesn't necessarily mean that you give up. It just means that you have to be adaptable. You need to find a way of finding out what works for you now. Being able to experiment and try positions that are both comfortable as well as pleasurable. Taking those changes into account. So for people, men, erectile dysfunction may be an issue. So being able to have the partner on top, that way the erection firmness is actually less important. For women, being able to have maybe an external lubricant that they can use as a way if they aren't finding they're well lubricated enough. And also, I think just continuing on that idea of expanding what sex actually means. That touching, kissing, massage, these are all sexual things. These are all things that bring pleasure. Being able to have oral sex or mutual masturbation as a way of being fulfilling substitutes for actual penetrative intercourse. And again, just moving towards that pleasure-based model. One of the easiest ways is changing the routine. If you find that sexual interactions always seem to happen at 8 o'clock on Thursday nights, being able to break through that routine, being able to say, okay, well, why don't we say 9 o'clock in the morning instead of 8 o'clock at night? Having, and adapting that to maybe when you find that you both have more energy. Maybe it's between breakfast and lunch. Maybe it's when you first wake up. Waiting to sort of initiate sexual contact at the end of a long day is not necessarily always the best way to go. And being able to really say that foreplay is going to be a more important aspect of a sexual interaction, and it may be actually end up being the main focus of the interaction. And that foreplay can be all of these things of taking your time, of being able to do things that aren't necessarily sexual, but are building a mood. And then again, trying to connect, trying to have maybe a night where you do all the things that you want to do, regarding music, regarding romantic music, or maybe you have a night when you only touch and kiss and you never go beyond that. Being able to be playful, I think, is really important. Being able to have a sense of humor, that sex doesn't have to always be such a serious thing. And being able to just laugh with your partner can actually be a really satisfying sexual interaction. Some of the ways that I have talked to people about is, things like game nights that have sort of a sexual twist to them. So again, like repackaging board games, things like, I don't know, for people who play Scrabble, any player that has a Scrabble word where they get more than 15 or 20 points gets 2 minutes of sexual attention. And it can actually be a very fun way of having a game night between two people. It may not be, the game is not necessarily the main focus, so you don't want to be hyper competitive, but the idea that there is the sort of extra sexual award and this, I think the anticipation can actually really build into a very satisfying experience. And then again, things like, as part of any game night, maybe writing down 5 things that you would like your partner to do to you, or things that you would like to do to your partner sexually, and have it sort of be, pull out of a hat. As far as the milestones along the game, may be a great way of sort of building in some intimacy and some sexual interactions into what would normally be a regular game. And I think, again, just making sure to remember that you don't want to obviously select things that that your partner is uncomfortable or feels devalued by, and making sure to have that discussion beforehand to discuss those parameters if you're unsure. And again, communication really is the key to all of these things, and making sure that you are comfortable with where you're going with the partner, but also where your partner feels. And lastly, I'll just touch on erotica, pornography. It's become very mainstream and obviously, unfortunately, very accessible. It does have a variety of modalities. There's, sort of something for everybody, I would say, at this point, and it may be something that provides immediate stimuli, and maybe for really advanced patients, it may actually be the easiest sexual outlet. But I think that it carries a lot of problems with it. One being that it really reinforces all of these things that I've just spent time talking about, as far as the expectations, the orgasm-based model rather than the pleasure. You rarely see real physical intimacy in these sorts of things. That acknowledge and that accessing some of these may actually lead to unfortunate things like malware, computer viruses, things like that may end up being real technical nightmares. And I think that, again, just that too much exposure to this type of stuff really destroys all the goals of intimacy that I just talked about. It may make your partner feel very uncomfortable as well. And again, that it may actually be a sign of the impulse control disorder that I touched on with the dopamine agonists. But I think more than anything that, erotica, maybe in a very benign and vanilla way, may be a real nice way of stirring up the mood a little. But I think hardcore pornography really does create a lot more problems than it does solutions. And I wouldn't necessarily encourage it unless it's something that both people feel very comfortable about. So I just want to acknowledge Sheila Silver and Gila Bronner, who both do a lot of sexual therapy talks, and that they've been very helpful in creating some of these presentations, and also the journalists John and Jane Doe for just some of the tidbits that I was able to acknowledge for them in this talk. Thank you so much. I think now I'm supposed to stop sharing, and I think we are leading into a Q&A.
Excellent. Yeah, so I've got a few questions that have rolled in here over your presentation.
Okay.
First one off here is, so I love my partner, but their body smells and tastes different now because of all of their medications. Is this normal? And is there anything that we can do about this or to help this?
That's a great question. I think that we all change as we go along, and as we age, our smells do change. I think that this would definitely be something to discuss with the neurologist. If there is a medication specific issue, that certainly being able to talk about that with the neurologist is a great place to start. And I think that being able to explore maybe if there are other things that are changing that taste or that smell as well, should be able to be discussed. I think that obviously that's going to be a hard conversation to have if it hasn't been brought up already. But again, just being able to openly communicate with somebody and acknowledging that is the first step towards trying to find a solution.
Excellent, thank you. I've got a couple more here. So my spouse with Parkinson's has lost all interest in any forms of intimacy and has no interest in doing anything about it. How can I get what I need?
Yeah, I mean, I think without talking to the person, that sounds like there's definitely some mood issues at play there. I would explore the ideas of depression, of apathy. Again, this is something that really should be brought up to the neurologist. I think that making a list of these types of things is really important to talk to the neurologist during a follow-up clinic visit. because too often I think that the visits get bogged down in the real physical symptoms, which I think are an important thing to acknowledge, but also that, that the idea that someone has lost interest in all intimacy and all interest in any sort of sexuality, I think is important to address. And that there are, I think, some solutions that are available, but first things first is the doctor needs to know about it.
Excellent, thank you. I've got another one here. So my partner is afraid they're going to hurt me because of my stiffness and rigidity with Parkinson's. How do I help explain that this is not the cause?
Yeah,
the case?
yes. Well, I think that communicating is the first step. That's a good place to start. Trying maybe to shift the sexual interaction into a way that seems to be more comfortable, that you appear to your partner to be in a much more comfortable state. I think that, again, just communication, like being able to constantly give that feedback, that you are feeling well, that this is not something that's hurting you. I think that being able maybe to be more of an initiator in sexual interactions may also help with that. If your partner is worried that you are going to be hurt, and yet you are the one who is pursuing and aggressing, may give them more of an idea that this is something that you really want and that you are comfortable with as far as the interaction.